Hello friends and welcome back to Parshetis Pulmonology. I'm very sorry that after a gap of 2 to 3 months I am coming in front of you because I was busy preparing for my super specialty exams. Okay, today I have come back with a very important topic. What are the newer changes in the goal 2024 that we'll be discussing here? There are totally 8 major changes from your 2023 guidelines. Okay, gold is a body which forms a guidelines for your guidelines in diagnosis and management of your COPD, that is chronic obstructive pulmonary diseases. Okay, coming to the first major change, that is your trajectory curve. As you all know, the lifespan of a person is divided into childhood, puberty, adulthood, and aging. Coming to the normal trajectory curve, such person will have normal lung functions at the birth, and these lung function peak during the puberty, and these lung function peak during the puberty, that is around 20 to 25 years of age. And as the age progresses, there will be physiological decline in the lung functions. That is your normal trajectory curve. Okay, so there are other two trajectory curves which he has given here. They are trajectory curve with a low lung function at the birth. That could be because of your prematurity, maternal smoking, maternal nutritional deficiencies, or because of the congenital malformations. When such babies they grow and they reach their puberty, they do not acquire the normal lung peak. They do not acquire the normal lung function peak, and they have low lung function during the puberty. And if such person smoke, there will be accelerated decline. Okay, and such trajectory curve we call it as an accelerated decline. Some babies, even though they have low lung function, they catch up. Okay, they catch up during the puberty because of the improved nutrition, improved physiotherapy, adequate medications. They catch up and they can have a normal trajectory curve. Understood? Some babies, they have growth failure and they have below normal lung functions, and such persons are more prone for your COPD. And some baby without, because of the fetal lung malformations, or because of the smoking, or because of the nutritional deficiency, or because of the post tubercular sequelae, or because of the pollution, they will have an severe accelerated decline and they can have premature death. One more entity which I has mentioned here is supranormal. Supranormal is the one which has normal lung functions at the birth, reach the puberty, but the decline during your aging, that is the physiological decline, will be less compared to your normal lung functions. That will be because of your no habits, adequate nutrition, adequate physiotherapy, adequate lung exercises. Such persons trajectory curve are known as supranormal. Okay, understood? Coming to the PRISM, PRISM, as you all know, it is preserved ratio, that is FEV1 by FVC more than 0.7 post bronchodilation, but the FEV1, that is impaired spirometry, that is FEV1 will be less than 80% of their reference after bronchodilation. This was there even in 22 and 23. What are the newer thing he has added? Newer thing what he says is, it is not a stable phenotype and it keeps on having transition between your normal and obstructed spirometry. So what are the risk factor which push it towards your obstructive spirometry are your lower FEV1, female gender, smoking, and the longer FET. FET is forced expiratory time. So these are the risk factors the patient has. Then there has higher chances of developing your COPD. And one more thing which he adds here is to consider, we should call this thing PRISM candidates as patient because they suffer from the symptom and they have low FEV1. And what is the exact treatment of this PRISM patient is not yet clear. It is based on the symptoms. If the patient has like bronchodilator, wheezing, we need to put him on the bronchodilator. But what bronchodilator exactly, it is not yet clearly mentioned. It is based on the clinical, up to your clinical acumen. Okay. Coming to the hyperinflation, hyperinflation is one of the important pathophysiology known from a longer duration. That is your high end expiratory lung volumes. Okay, compared to your normal, because there will be, because of the air stacking or the air trapping in the lungs, the person will have dyspnea, the person will have exercise intolerance, increasing number of hospitalization. So what are the newer thing which he has added here is treatment of hyperinflation. He says treatment is, as you all know, bronchodilators and the chest physiotherapy. Chest physiotherapy, it is your pursed lip breathing. Pursed lip breathing, where the person during expiration make the lips as a pursed lip, so that we can create an auto peep. So it will prevents the collapsibility of the airway because of the lack of elastic recoil. Okay. Coming to the blood eosinophil level, as you all know, blood eosinophil acts as a surrogate marker to add inhaled corticosteroids in COPD. We have three levels. Less than 100 we don't add. Between 100 to 300 we add it when the patient has more than or equal to 2 moderate exacerbation. And if the patient has more than 300, we add it despite or regardless of your exacerbation. What is the important thing that he mentions here is the patient with higher eosinophils level who are not on ICS, they have greater decline in the FEV1 compared to the person who does not have higher eosinophil level. Okay, understood? 2%, one with higher eosinophils, one with normal eosinophils. Both have COPD. One with the higher eosinophils level, if he is not put on ICS, has a greater decline in the FEV1. That is what he mentions here. Okay, that is what is a newer point in the blood eosinophils in COPD. Interstitial lung abnormality, this term you might have heard in the latest IPF and PPF ATS guidelines, which was released in the May 2023. This time he has added it even in the gold guidelines. What he says that when we get a HRCT thorax or the X-ray of a COPD person, we can find many of the time parenchymal lung fibrosis and inflammation. But the patient is not symptomatic for ILD. Only there is a parenchymal fibrosis or inflammation, but the person is only symptomatic for COPD, not for ILD. Such patients we call it as interstitial lung abnormality. When both ILA and your COPD are combined, there will be prognosis is poor. That is what he mentions in the interstitial lung abnormality. Okay, we sometimes call it as CPFA, combined pulmonary fibrosis with emphysema. Prognosis is poor. Vaccination, the newer vaccination which he adds here, is newer respiratory syncytial virus for the patients above the age of 60 years. Okay, remember RSV vaccination, because most common cause for acute exacerbation of COPD is virus. Okay, so the most among them, the most common is respiratory syncytial virus. So he has added vaccination here in this 2024 for the person with COPD above the age of 60 years. Choice of inhaler device, if you're using a dry powder, the patient inspiratory capacity should be good. If the patient inspiratory capacity is not good, we need to go with middle dose inhaler, but we need to have good coordination. Okay, that is important. The patient does not have good coordination, no good inspiratory capacity, go with inhaler. Go with nebulization, sorry, go with a nebulization. Understood? Important thing which I added here is pre-bronchodilator PFT. As you all know, for diagnosis we use post-bronchodilator FEV1 by FEC, but here he has added pre-bronchodilator PFT. What he says, the patient is symptomatic. If the patient has symptoms of COPD like smoke, cough, wheeze, dyspnea, and chest tightness, and you do pre-bronchodilator FEV1 by FEC, and if it is less than 0.7, you need not perform post-bronchodilator. Okay, you do not perform post-bronchodilator. But if the FEV1 by FEC is less than 0.7 and you have a strong clinical suspicion of COPD is suspected, then we need to perform a post-bronchodilator PFT. Understood? In symptomatic patient, if pre-bronchodilator is not showing any obstruction, then you need not perform a post-bronchodilator PFT, because unlikely the FEV1 by FEC is going to go below 0.7. But symptomatic patient, pre-bronchodilator FEV1 by FEC less than 0.7, but you're strongly suspecting COPD, perform post-bronchodilator FEV1 by FEC. Okay, understood? Symptomatic patient, pre-bronchodilator, there is no obstruction, post-bronchodilator PFT is not necessary. But if there is a strong clinical suspicion of COPD, perform a post-bronchodilator FEV1 by FEC. Okay, these are the total 8 major changes. Okay, thank you all for your patient listening. Please like, share and subscribe Perchetis Pulmonology. Okay, I'll be doing videos now regularly based on your pulmonology topics. If you have any topic which you want me to do a video on, please mention it in the comment box. If you have any doubt, please leave it in the comment box. Thank you all for your patience listening. Thank you.